The lecture of today is about postpartum hemorrhage. The uterine blood flow in non-pregnant women is about 55 ml per minute. This will increase in pregnancy, reaching maximum in the third trimester, which is about 900 ml per minute. So, a huge amount of blood going through the uterus to the placenta. This blood has to be stopped after delivery or after separation of placenta. So what is the mechanism of hemostasis after delivery? There are two mechanisms. Number one, uterine contraction and retraction. By this we mean that the uterus at time of pregnancy is at the level of xiphisternum, but after delivery, immediately it becomes just below the umbilicus. This is due to contraction and retraction of myometrial muscle. And in addition, the myometrial muscle consists of three bundles of fiber, longitudinal, circular, and oblique, and these act as a grid and constrict the vessel in between, leading to stop of the bleeding after delivery. The second mechanism is platelet aggregation and activation of clotting system. Regarding the definition of postpartum hemorrhage, defined as blood loss of more than 500 ml at vaginal delivery and more than 1000 ml at cesarean section. The American College of Obstetrician Gynecologists defined postpartum hemorrhage as 10% drop in the hematocrit or the need for blood transfusion during the first 24 hours after delivery, while severe postpartum hemorrhage defined as more than 1000 ml at vaginal delivery. The types of postpartum hemorrhage can be divided into primary, which occur within the first 24 hours after delivery, or secondary, which occur after 24 hours till the end of the puerperium, that is 6 weeks or 42 days. The incidence of postpartum hemorrhage varies between 5 to 15%. Now we discuss primary postpartum hemorrhage. What are the causes of primary postpartum hemorrhage? The causes of primary postpartum hemorrhage can be summarized as 4T: tone, trauma, tissue, and thrombin. Tone, which is inability of the uterus to contract and retract, and this represents the majority of the causes of postpartum hemorrhage, represents 70% of the causes of primary postpartum hemorrhage. Trauma, due to laceration, hematoma, uterine inversion, or rupture uterus, and this represents 20% of the causes of primary postpartum hemorrhage. Tissue, which is either due to retained placental tissue or morbidly adherent placenta, or what is called placenta accreta. This represents 9% of the causes. And last one is thrombin due to coagulation defect, and this represents just 1% of the causes of primary postpartum hemorrhage. And now we discuss each of them in details. The first T, which is the tone or uterine atony or inability of the uterus to contract. The predisposing factor for uterine atony include the following. Number one, overdistension of the uterus, as in case of polyhydramnios, multiple pregnancy, and macrosomic baby. Number two, intra-amniotic infection. This is either due to fever of any cause or prolonged rupture of the membranes. Number three, uterine relaxing agent like nifedipine, magnesium sulfate, terbutaline, halogenated anesthesia like flothane, and glyceryl trinitrate. And number four, we should not forget bladder distension as one of the causes of uterine atony, so it is important in the management that we should empty the bladder. The second T is trauma, and trauma to the genital tract include laceration of the cervix, vagina, or perineum. This occurs in precipitated delivery and in operative deliveries like ventouse or forceps deliveries. Second one is extension and laceration at cesarean section. This occurs in malposition and if the presenting part is deeply engaged. Number 3, rupture uterus, and this occurs if the patient have previous surgery on the uterus like cesarean section or myomectomy. So any scar in the uterus liable for rupture. Number 4, uterine inversion, and this occurs in the mismanagement of third stage of labor and in multipara with excessive cord traction. The third T is tissue, which is either due to retained cotyledon or succinturate loop of the placenta or due to placenta accreta, which is morbidly adherent placenta to the uterine scar. The last one is thrombin, which is due to coagulation defect either present before pregnancy, like idiopathic thrombocytopenic purpura or von Willebrand disease, or acquired in a pregnancy, example gestational thrombocytopenia or preeclampsia with thrombocytopenia. Number 3, it may be due to DIC, which occur as a secondary complication to some obstetric condition. Example of these obstetric conditions which lead to DIC, gestational hypertension with or complicated by HELLP syndrome, intrauterine death, severe infection, abruptio placenta, amniotic fluid embolism. And number 4, if the patient on therapeutic anticoagulant like heparin and Clexane. The clinical presentation of postpartum hemorrhage is vaginal bleeding plus symptoms of blood loss, and the symptom of blood loss depend on the degree of bleeding the patient have, ranging from palpitation, tachycardia in mild cases to lethargy, air hunger, anuria, and collapse in advanced cases. Now, the complication of postpartum hemorrhage include shock state, DIC, renal failure, puerperal sepsis, blood transfusion reaction, thromboembolism, Sheehan syndrome, and we have to remember here that the first sign of Sheehan syndrome after delivery is absence of lactation. Also, you have to remember that more than 25% of maternal death are due to postpartum hemorrhage, especially in developing countries, including our country, and it is regarded as preventable death. So, how we prevent postpartum hemorrhage? Prevention includes regular antenatal care for all pregnant women. Number 2, correction of anemia and malnutrition. 3, identifying women at risk of postpartum hemorrhage. Example, pregnant women with overdistension of the uterus like multiple pregnancy, polyhydramnios or macrosomic baby, pregnant women with a previous cesarean section, pregnant women with bleeding disorder. All these patients should identified as a risk woman, and they should be delivered in a tertiary center with all facility for emergency obstetric care. Number 4, there should be emergency referral facilities for all units containing labor ward, so that if any postpartum hemorrhage occur, they can transfer immediately to tertiary center with or for definitive management. Number 5, routine active management of third stage of labor should be done in all labor ward. This is done by administration of oxytocin, either 5 unit intravenously slowly or 10 unit intramuscularly, early cord clamping, controlled cord traction, and inspection of the placenta for the presence of missing cotyledon. Management. The management of primary postpartum hemorrhage, including resuscitation and stop the bleeding. If you remember in antepartum hemorrhage, we say that we do resuscitation, then we do the definitive management. But here, both resuscitation and definitive management should be done at the same time. So the first thing is to call for help. Here we have to call the most senior obstetrician, the midwife who trained in management of postpartum hemorrhage. We should call senior anesthetist, and we should call hematologist and all the staff who involved in the management of postpartum hemorrhage. We should take care of the airway, breathing, and circulation. We should put oxygen by face mask. 2 IV lines should be inserted using cannula gauge 14. At the same time, we draw blood, 20 cc of blood for blood grouping, cross-matching, and prepare 4 to 6 units of blood. We also do coagulation screen, and sometimes we need to do renal function and liver function test. Of course, the patient needs blood, but until blood is available, we have to give IV fluid, and the IV fluid should be warm. And we have 2 types of IV fluid, either crystalloid, like normal saline or ringer lactate. We give 2 to 3 liters of crystalloid IV fluid, or sometimes we give colloid fluid like Hemasil. Avoid giving hydroxy starch because it interferes with blood grouping and cross-matching. In life-saving condition, where blood is not available, we can give Rh negative O blood group until the blood is available. Also, we have to put Foley's catheter for 2 reasons. First, to assess renal function because they are liable for renal failure. And second, to empty the bladder because, as we said, distended bladder may cause uterine atony. So these are the steps initially done in postpartum hemorrhage. At the same time, we have to stop the bleeding. Then how we stop the bleeding? As we said, the major cause of bleeding is due to uterine atony. How we diagnose uterine atony? Uterine atony diagnosed by examination. We find the uterus above the umbilicus, maybe at 28 weeks or at 30 weeks level, and it is soft in consistency. In such case, we have to start our measure to stop the bleeding. The treatment of uterine atony is by mechanical, pharmacological, and surgical method. The mechanical method, we should rub the uterus or massaging the uterus immediately. So the first point is to do uterine massage, both hands on the abdomen. Second mechanical measure is by manual compression. Here we put one hand in the vagina and the other hand in the suprapubic region and try to compress the uterus between the 2 hands. The 3 aortic compression against sacral promontory, here to decrease the blood supply to the uterus. This is temporary measure used just to get assistance or to get blood for the patient and to think about next step. At the same time, we should give a drug to maintain uterine contraction. So the pharmacological method to stop the bleeding include the following. Oxytocin. Oxytocin giving either 5 international unit slow intravenous injection or 10 intramuscular unit injection. Then maintenance dose 20 to 40 international unit in 500 ml normal saline, and the rate of infusion is 125 drop per hour. The second drug is ergometrine. The ampoule contains 0.2 milligram. We can give 2 ampoules or 0.4 to 0.5 milligram intravenously slowly, provided that there are no contraindication for ergometrine. Now, the major contraindications for ergometrine including hypertension, cardiac disease, sickle cell anemia, and bronchial asthma. Other drug, is carboprost, which is prostaglandin F2 alpha. The ampoule contains 0.25 milligram. This is given intramuscularly and can be repeated every 15 minutes until 8 doses or 2 milligram. And the major contraindication is bronchial asthma. Other drug is misoprostol, or called cytotic tablet. Each tablet contains 200 microgram. We can give 4 tablets or 800 microgram either rectally or sublingually. Also, we can give tranexamic acid or cyclocapron 500 to 1000 milligram intravenously slowly. Regarding the use of recombinant factor 7, it is not routinely recommended in the management of major postpartum hemorrhage unless as part of clinical trial or research. So all these measures used to treat uterine atony first. If these measures fail, then we shift to surgical technique for postpartum hemorrhage due to uterine atony, and these include the following. Tamponade. By tamponade, we mean we insert something inside the uterus to stop the bleeding by compress the uterus. An example of these, Bakri balloon inflated inside the uterine cavity under general anesthesia, Singastaken tube, Rush balloon, and Foley's catheter. And we have to remember here that Foley's catheter contains small balloon, so it is used just in case of bleeding from the lower uterine segment, as in case of placenta previa. Also, we can do packing of the uterine cavity with gauze. This is one of the methods of tamponade. If tamponade doesn't work, then we shift to surgery. We do laparotomy, and we can do uterine artery or uterine devascularization, stepwise uterine devascularization. By this we mean we cut the blood supply to the uterus, starting with bilateral uterine artery ligation, then we do ovarian artery ligation, and then we can do bilateral internal iliac artery ligation. Other surgical method is using B-lunge brace suturing. By this we compress the uterus between suture going through both sides of the uterus. Also, some modality of treatment is uterine arteries embolization. This is done by interventional radiologist, by which we inject thrombus and block the uterine arteries to stop the bleeding. If all these measures fail, then the final decision is hysterectomy to stop the bleeding and save the life of the patient. This is regarding uterine atony. Now, what about other causes and how we manage? The second cause is postpartum hemorrhage due to trauma. Now, when we suspect that the patient have trauma to the genital tract, of course it occurs in difficult labor and instrumental delivery. We suspect it when we examine the uterus and find the uterus just below the umbilicus and firm in consistency, but the patient still have vaginal bleeding. In such case, we suspect trauma to the genital tract, and this patient should be taken to the theater for examination under anesthesia and exploration of the genital tract to see where is the injury. We start from the uterus from upward downward, starting from the uterus to see if there is any hole inside the uterine cavity, and if there is hole, it means rupture uterus and the patient need laparotomy. Then we check the cervix. Checking the cervix require Sims speculum and 2 sponge forceps. We put 1 sponge forceps in the anterior and 1 in the posterior lip of the cervix and grasp the cervix. Then we rotate the sponge forceps in anti-clockwise direction to see the all part of the cervix, and if there is injury, we suture it immediately. After we finish from checking of the cervix or suturing, we have to check the vaginal wall. So we push the cervix by packing or by gauze and examine the vaginal wall for any episiotomy extension, injury, laceration, or hematoma, and should be repaired quickly. This is example of cervical tear suturing, and this is example of vaginal tear suturing, and this is example of rupture uterus which need laparotomy, and this is example of uterine inversion which need correction immediately. The third causes is retained placenta, tissue or retained either pieces of placenta or the whole placenta. Also, this patient need to be taken under general anesthesia and doing manual removal of placental piece under general anesthesia. And you can see one hand inside the uterus, the other hand over the suprapubic region, catching the fundus of the uterus to prevent complication. And if the whole placenta adherent, like in case of placenta accreta, in such case hysterectomy is the treatment of choice. The fourth causes or the fourth T of primary postpartum hemorrhage is thrombin or DIC. So how we manage DIC? The management of DIC is by fresh blood transfusion and by blood product. The blood product including cryoprecipitate, fresh frozen plasma, and platelet concentrate. The fresh frozen plasma, the bag contains 200 to 250 ml. It is ABO compatible. The dose of fresh frozen plasma, either after each 4 units of blood, we give 4 bags of fresh frozen plasma, or we calculate the dose according to the body weight, which is 10 to 12 or to 15 ml per kg. The second blood component is a cryoprecipitate. This is necessary if fibrinogen level is low. So to increase fibrinogen level, we use cryoprecipitate. The bag contains 25 ml, and we can give 2 to 10 units to raise the fibrinogen more than 150 milligram per dl. The third is transfusion of platelets concentrate. The indication for transfusion of platelets concentrate is if the level of platelet below 75,000. The platelet concentrate, as you know, it requires multiple donors, sometimes 4 to 6 units of patient from multiple donor, and it is doesn't need blood grouping and cross matching, and each unit raises the platelet by about 20 to 30,000. So this is regarding treatment of thrombin. Regarding secondary postpartum hemorrhage, how we treat? First of all, we should assess the vaginal microbiology by taking high vaginal swab, and we should use appropriate antibiotic, and the drug of choice in such cases is clindamycin. Then we have to do pelvic ultrasound to see if there is any retained placenta or retained piece of placenta, and then we decide for surgical evacuation of retained placenta, which should be done by experienced clinician to avoid the complication of Asherman syndrome. Thank you.